Medeiros. It's an honor to have been invited to be one of the speakers for pathologists online. I did my medical school in Brazil, and then I came to the United States and did my residency in anatomic pathology at the Brigham and Women's Hospital in Boston, followed by a Women's and Perinatal Pathology Fellowship also at the Brigham. Then I went to the Mayo Clinic, where I did a surgical pathology fellowship and a molecular genetic pathology fellowship. I stayed then on faculty at Mayo and practiced primarily gynecologic pathology, frozen section pathology, and also molecular genetics. After that, I actually lived in Europe for a year and a half, primarily in Italy, because in addition to being a Brazilian citizen, I'm an Italian citizen, and I basically studied Italian. I studied Italian arts and history. I really had a great time in Europe. But then I had to come back to the United States, and I did an additional fellowship in cytopathology at University of Southern California in Los Angeles. Soon afterwards, I joined the staff, the faculty at USC, doing primarily gynecologic and placental pathology and cytopathology. And then afterwards, I spent still a year in private practice, and finally, 2 years ago, I joined Cedars-Sinai Medical Center in Los Angeles as Director of Gynecologic, Placental, and Perinatal Pathology. I hope you enjoy the sessions and learn a lot from them. Thank you.
This is Fabiola Medeiros from Cedars-Sinai Medical Center in Los Angeles, recording a session for pathologists online on the topic of placental pathology. I'll cover quickly some basic parameters you should consider when looking at placenta, quickly review the histology, and then move on to three pathologic processes: meconium staining, ascending amniotic fluid infection, and villitis. Basic parameters that you should take into consideration are gestational age, and in this figure I show the definition of term for pregnancy. So early term, full term, late term, and post term. And then it's very helpful to have handy weight charts. There are many available in textbooks and in articles, and it's usually good to use a weight chart that is more in keeping with your population. And then, of course, there are many things that you can see on gross examination that we're not going to be covering in this session. When you get these slides, I recommend that you perform a compartmentalized approach. I usually start with the umbilical cord, and then I move on to the fetal membranes, the chorionic plate, the basal plate, and finally the parenchyma, moving from stem villi to distal villi, and then evaluating the intervillous space. And the reason for that is because placental slides have a lot of information. So if you do not adopt this compartmentalized approach, chances are you can miss a significant lesion. So the placenta is a mixture of maternal and fetal tissues. The majority, of course, are fetal tissues. So we start here with the umbilical cord, which contains the fetal vessels that then branch into the chorionic plate. This is the fetal surface grossly. And the vessels from the chorionic plate further branch down the villi from stem villi to intermediate and distal villi. And then maternal tissue that is attached to the placenta is the decidua. You have the decidua basalis here just below the placenta per se, and then around the baby here in this area would be decidua capsularis. And maternal blood flows into the intervillous space from the maternal arteries and go back from the maternal veins. So as I said, the placenta has both fetal and maternal tissue, and this is a basic outline of which is which. Again, majority is baby, decidua and intervillous space is mom's, as far as some of the fibrin that you see throughout the placenta that we're going to show later. So the umbilical cord contains two arteries that carry venous blood and one vein that carries arterial blood, and those vessels are then enveloped by the Wharton's jelly and further lined by amniotic type epithelium. So this is a microscopic view of an umbilical cord in a term placenta. So the vein usually has the most dilated lumen and the thinner wall, while the arteries have a thicker wall and a more like compressed lumen. And then this is the Wharton's jelly. It contains these clefts, which are real spaces in the placenta because the placenta does not have lymphatic vessels. So that does they do work as fluid channels. And then this is the amniotic lining that we can see partially here. Of course, it will go all the way around the umbilical cord. And then as fetal membranes, we have amnion, chorion, and the vestigial capillary. So when you look at your membrane roll, that's what you should be seeing. So the amnion has a top line of amniotic epithelium, which are these cells, and then they are underlined by amniotic mesoderm, which is this collagenous area. And then right here we hit the start of the chorion. So the chorion has a chorionic mesoderm, which is this area here. And then it has a trophoblastic layer, which are these bigger cells right here. Between the chorion and the amnion, there is a true layer that is called spongiotica. So this space is actually real, and you see not everywhere, but in most places. And then below the chorion, we have the vestigial capillaries, and that belongs to mom. So these tiny little vessels here are mom's vessels. Oftentimes when you look at membrane roll, you're going to find these structures here. Those are remnant villi. So in the beginning of pregnancy, the whole gestational sac has villi structures all around. Later on, as the placental parenchyma, placental just develops, those villi they get atrophic and they get incorporated into the fetal membrane. So that's what we're seeing here. And of course, the structures here are glands in the decidual that you see remaining sometimes. This book is a great book for all levels, from resident to attending. It is summarized, is a summary of Berniski and Kaufman placental pathology. However, it's very practical, has very nice diagrams that I have included here for your reference. The chorionic plate is basically a modified fetal membrane. It also has amnion and chorion, but we don't have the spongiotica so well developed, and the boundaries are a little bit more blur. So in the chorionic plate, what usually you're going to see is the lining epithelium, some amniotic mesoderm, some chorionic mesoderm, and the trophoblastic layer is different. It's not contiguous, and it's just like this extravillous trophoblast floating in fibrin. And then the chorionic plate, of course, contains vessels. Those are branches of the umbilical cord. They're called chorionic plate vessels, and they're actually very important in the placenta for the blood flow. And here again is another schematic from the book that shows very nicely what you expect to see in the chorionic plate. Then moving on to chorionic villi, in a mature placenta, meaning a third trimester placenta, we have three main types of villi, and those are stem villi, mature intermediate villi, and terminal or distal villi. Stem villi are these large ones that have a fibrotic stroma, and they have arteries and veins with obvious like thick muscular walls. So they're basically just conduits. There is no gas exchange that occurs here. And then we move on to the mature intermediate villi. They have a more loose stroma. Oh, sorry, that's a typo. It should be collagen, poor in collagen. And they have capillaries, arterioles, and venules. So that's how they look like. That's an intermediate villus here, and it's surrounded by distal villi. But as you can see, it does contain vessels with a very subtle layer of muscle. These are this is another intermediate villus here, and up here we'll nicely see again the muscular arterioles. Terminal villi are the smaller villi. Overall, if you get the entire placental parenchyma, they correspond to about 50% of the entire volume. They only contain capillaries, and those capillaries usually dilated and packed with red blood cells, which are fetal red blood cells. And pretty much by definition, even though it's a loose definition, a cross-section of a terminal villus contains about 50% of the area taken up by the vascular lumens. So this is one picture that contains only distal villi. Normally they have 3 to 5 capillaries, and these capillaries, they touch the periphery of the villus. So as you can see here, these capillaries here are touching the trophoblast, right? So that's called vascular syncytial membrane, is where the gas exchanges occur, gas and nutrient exchanges. Here, the intervillous space is maternal blood, while inside these capillaries, that's fetal blood. Here's another nice picture showing some very nice vascular syncytial membranes for gas exchanges. So that's a mature placenta. And then throughout the placenta, we have a lot of fibrin and fibrinoid. So fibrin is basically the result of clotting of maternal blood, and fibrinoid is the extracellular material that is secreted by extravillous trophoblastic cells, and they mix up throughout the placenta. And then we have placental septa and cell islands. So fibrinoid can be incorporated inside the villi, and that's an example here. They can be around the villi. Most of the stem villi will have some sort of perivillous fibrin fibrinoid. Here's some perivillous in a smaller distal villus, and here in proximal stem villi. And then, of course, you have a lot of it subchorionically. This is not something you need to worry about. It's normal. It only becomes abnormal when it's very diffuse and thick. There is a condition called massive subchorionic villus, massive subchorionic fibrinoid deposition that is abnormal, but it's extremely rare. And then, of course, we have placental septa, which are invaginations of the basal plate into the placenta. They're incomplete septa. And then sometimes we also have extravillous trophoblast and decidua forming the cell islands throughout the placenta. And another very important component, of course, of the placenta where the maternal blood inflow comes from is the basal plate. So the basal plate has many layers, as we can see here on the left, but they usually are not very well defined. So basically what you see is a mixture of fibrin and fibrinoid, extravillous trophoblastic cells, and then the decidua basalis. And even on this power, we can tell which one are trophoblasts and which ones are decidua, because the trophoblastic cells, they are bigger and more atypical, while the decidual cells that we see here, they are much smaller and they have blender nuclear features. And of course, I think most people are familiar with that. I didn't mention we have also the villus trophoblast, which is the cytotrophoblast and syncytial trophoblast that surround the villus per se. But these cells here are extravillous trophoblastic cells. So we'll be starting with meconium. Meconium is actually fairly common. It's reported in 12% of all deliveries and 30% of postterm pregnancies. It's less common in preterm, but it has greater morbidity when it occurs in preterm. It has been shown that the frequency of meconium discharge and meconium staining increases with intrauterine fetal distress. Despite that, though, it's still controversial if meconium is always pathogenic. I think that there is evidence and opinions from experts in both directions. Some experts say meconium is always pathogenic, even at term, and some experts say it's not always pathogenic, particularly at term. And as we can see from this table from another excellent placental pathology book that I recommend that was recently published, this table is very helpful and it shows you the timing of meconium exposure and how important that is. So first, you're going to have some different gross and microscopic findings depending on how long the meconium exposure has been, and also the effect on the fetus and neonate greatly increases as the timing of meconium exposure increases. So we basically go here from less than 3 hours with basically no meconium sequelae, all the way to 12 to 16 hours when there is really a risk for fetal demise and neonatal meconium aspiration syndrome with neurodisability. So it's important to take this into consideration when looking at meconium. It's not the current clinical practice to actually provide this type of information in pathology reports, but of course clinicians are familiar with this concept of prolonged and thick meconium, and this is critical for medical legal cases. So green membranes, everybody has seen that. So meconium can be reported actually in many different manners. If you see intrapartum meconium, that's already meconium because it takes about an hour for meconium to actually stain the membranes, but still there is meconium. So in my reports, I usually say meconium detected intrapartum for those cases. And then of course we have meconium grossly that we're seeing here, and this is green, so it means a more recent meconium. As time passes, as hours pass by, the meconium will become more brownish in color. Now I'll be reviewing some slides on meconium staining of fetal membranes. The first thing you're going to see on low power is subamniotic edema, and that's what we're seeing here. So here we have the subchorionic area greatly expanded by edematous fluid, and then we have the collection of these histiocytes with meconium staining. We can see the brownish golden fine pigment within those cells. I have marked this area here in which we have some very nice histiocytes, which are also called meconiophages. So these are meconiophages here, which is evidence of meconium deposition in the amnion. Later on, you're going to see them in the chorion and the decidual capsularis. This is a more severe case of meconium in which the subamniotic edema is even greater. So the subamniotic area is greatly expanded. And what we see, in addition to meconiophages, which we see down here, we see this. This is also meconium here. This is particulate meconium. So this is another form of meconium. We have also some neutrophils here, some nucleated squamous cells. But overall, that's what we're seeing, great evidence of meconium. Another thing that you see with meconium, let me see if I can find a good area, is thickening and eosinophilia of the basement membrane of the amnion. So that's something we see here. And we also start seeing some vacuolation of the amniotic lining cells. In some cases, this reactive change of the amnion is very pronounced. So this is a case here of in which we see the piling up of amniotic epithelium with vacuolation of the cytoplasm and degenerative changes. This is basically meconium toxicity, all the way sometimes that the amniotic lining cells can become actually necrotic. So another scenario we see quite often with meconium is sloughing off of the amnion. So here we have a membrane roll, and when we look at this membrane roll, we notice that we have chorion. So we have here the chorionic cells, the trophoblastic cells of the chorion. We have some chorionic mesoderm up here, but the amnion is no longer there. So the amnion in all these layers of the membrane roll is absent, and that's sloughing off the amnion, and that happens because meconium makes the membrane slimy. So the amnion slides off and gets detached, and oftentimes you'll get necrotic. So this is another effect of meconium that you're going to see in the fetal membranes. But the most severe finding associated with meconium is actually not in the membranes, is in the umbilical cord.
So here we have an umbilical cord with the vein up here and two arteries. And this is something you pick up on low power. So closer to the lumen, we have normal smooth muscle right here. So we have normal smooth muscle cells here, up here as well. But then these cells, they are smooth muscle cells, but they're not normal. Those are apoptotic smooth muscle cells. And this is called myonecrosis. So this is myonecrosis of the umbilical vessels. It's actually affecting both arteries. You can see it in this artery and this other artery. And the problem with this is that it will lead to a collapse of the vascular wall and vascular lumen and some very deleterious effects, commonly intrauterine fetal demise or some neurologic disability.
Now we're going to discuss ascending amniotic fluid infection. This type of infection arises from the cervicovaginal region and usually caused by bacteria and leads to almost always a maternal inflammatory response and in some cases also a fetal inflammatory response. There are some differences between preterm and term chorionitis. 40% of all preterm placentas have been shown in some studies to actually show histologic chorionitis, and the great majority of those cases have positive cultures. So, meaning we really believe it's a true infection. While at term, the overall prevalence of chorionitis is lower, but a lot of those cases have negative cultures, what makes us think that maybe they're not infectious in etiology. There is also some differences between clinically detected and pathologically detected chorionitis. About 25% of cases that clinically are suspected to represent chorionitis are not confirmed histologically. And there is also the situation in which you see histologically chorionitis, but there were clinically no clues of an ascending amniotic fluid infection. So, according to the Amsterdam Consensus, which we also call Amsterdam Criteria, very important paper to read if you practice placental pathology. It was published a few years back, and it's very helpful. It does recommend staging and grading of maternal and fetal inflammatory responses. And the reason for that is because the rates of neonatal infection and the influence in fetal and neonatal outcome will correlate with the stage and grade of maternal inflammatory responses. So the stage is basically where in the placenta you see the inflammation, and the grade is how severe the inflammation is. For maternal inflammatory response, we go from stage 1, that is acute subchorionitis and chorionitis, to stage 2, which is chorioamnionitis, to stage 3, which is necrotizing chromionitis. And then for fetal inflammatory response, we go from stage 1, that is chorionic vasculitis and umbilical phlebitis, to stage 2, that is arteritis practically, and stage 3, necrotizing funisitis. And basically grade 1 is mild to moderate, and grade 2 is severe. And severe is when you start having clusters, confluent clusters of neutrophils. Before I move on to the slides, I'm going to show you this slide here. Of course, usually when you have severe amniotic fluid infection, what you're going to see is a purulent yellow membrane, sometimes like foul smelling. This is a different type of ascending amniotic infection that I'm going to show later on the slides. We see these little tiny dots here on the umbilical cord surface, and also on cross sections we see these little like round structures, and I'm going to show you what this is under the microscope.
I'll now be sharing with you some slides that illustrate the concept of staging and grading of ascending amniotic fluid infection. This is the first stage we see here. This is the chorionic plate. And when you look on a higher power in the subchorionic area, so this is the chorionic plate. When we look at the subchorionic area, we see margination of neutrophils here.
those come from the intervillous space, so they are mother's neutrophils. So they marginate and form this band below the chorion in the chorionic plate. That's called acute subchorionitis. And then when they actually infiltrate the tissue, which is something we're seeing right here, that's already chorionitis. But really the main place to look for maternal response in amniotic fluid infection is the membrane wall, right? Are the fetal membranes. So in this area here, we have the decidual capsularis, and we have neutrophils here within the decidual capsularis. That would be an acute deciduitis. And then we see neutrophils here marginating in the chorion. So the chorion has two layers, right? It has the trophoblastic layer, which are where the trophoblastic cells are, and we can see the neutrophils. And then it has the chorionic mesoderm, which is this layer right here. And then the amnion. So as you can see, there is a basement membrane here within the chorion, and it's very common that will form a barrier against neutrophils. Still, some of them do pass by and move up to the mesoderm of the chorion, to the spongiotica, and to the amnion per se. In this other area here of the same case, we have what I showed was mild grade 1 inflammation, but then in some other areas of the same case, we have much more severe inflammation. So here we have a full-blown acute choroimmunitis in which we have neutrophils from the decidual capsularis growing into the chorion, trophoblastic layer of the chorion, mesoderm of the chorion, and finally here the amnion per se, right here. And of course, when we have abscesses like confluences of neutrophils, that's already a grade 2. So this is severe. So this is choroimmunitis with stage 2 for maternal response, and this is grade 2 for maternal response because we have severe acute inflammation. And then as far as the fetal inflammatory response, we can see that in the chorionic plate. And we can also see, of course, in the umbilical cord. So here again, we have two arteries and one vein. And when we look at the vein, we see neutrophils growing from the lumen of the vessel into the muscle wall and into the Wharton's jelly. So this is acute phlebitis. So this is a stage 1. If we move to this artery here, usually the inflammation starts in the vein, by the way, so usually the response in the artery is not as marked, but this artery has neutrophils within the muscular wall as well. So this is a stage 2 for fetal inflammatory response. When we get to necrotizing chromionitis, which is this case here of a preterm placenta with intrauterine fetal demise, actually, because it was so severe, it caused what we call an inflammatory abruption. So here, what we see is like a sea of neutrophils. The amnion itself is necrotic, but not only that, the neutrophils are necrotic. So we see this purple dust. So this is necrotizing acute choroimmunitis, and this is stage 3 for maternal inflammatory response, grade 2 because it's severe. We also have a higher stage, stage 3 for fetal inflammatory response, and that's something that we see in the umbilical cord. So that's what we're seeing here. This is concentric perivasculitis. We are in the umbilical cord, we have an umbilical vessel, we have neutrophils migrating from the lumen all the way down to the muscular wall and then to the Wharton's jelly, and we can see it for the inflammation forms this ring around the vessels. So that's concentric perivasculitis, and we're seeing these vessels here. By Amsterdam criteria, you should have necrotizing perivasculitis, which this is. So again, the neutrophils per se are necrotic. We see apoptotic bodies everywhere. So this is basically necrotizing funisitis, concentric perivasculitis, and this is stage 3. So the chances that there will be a poor prognosis for this fetus or neonate are quite high when you get to this high level of fetal inflammatory response. And by the way, neurologic impairment and cerebral palsy has been shown to be more related
correlate more with fetal inflammatory response rather than maternal inflammatory response, and it's believed that the cytokines that are released in the fetal circulation do play a role in causing neurologic injury. This is another case. This is that gross picture that I showed. It does have chorionitis, but in addition to that, when we look at the umbilical cord, we see what those white areas were grossly are these microabscesses. So we see microabscesses at the periphery of the umbilical cord just below the amniotic layer. So we see this collection of neutrophils. This is classic. This is a classic association for Candida funisitis, and we see it here again. And this is what this is. We don't actually see the fungal forms on H&E, but this is the GMS stain. Let me find the best area. Here is one of those microabscesses. And we see fungal forms of GMS stain. And these fungal forms are pseudohyphae and yeast consistent with Candida. So this is an immediate call to the clinical team because oftentimes they do not know about the Candida infection, and a small proportion of these babies can develop neonatal candidiasis infection, systemic infection. It's a small proportion, but still it does deserve a call to the clinical team.
We're now going to cover villitis. This is the way I summarize usually villitis. The most common form is called chronic villitis of unknown etiology. And then very rare are infectious chronic villitis, usually caused by torch infections. Then we have a category of villitis in which we do not identify organisms, but in which we still suspect there could be an infectious etiology. And finally, we have acute villitis. So chronic villitis of unknown etiology, as I said, is the most common subtype of villitis that we're going to see in placental pathology. And those typically occur in normal term pregnancies with normal newborns. And this is characterized by a lymphohistiocytic inflammatory infiltrate that is patchy, meaning the areas that are inflamed look abnormal, but the areas away from the inflammation look actually quite normal. This is graded as high or low grade. You can check the Amsterdam criteria paper for the grading criteria. And only the high grade form has been associated with IUGR, neurodevelopmental impairment, and actually high grade chronic villitis of unknown etiology has been also associated with some increased risk of recurrence at 10 to 15%. So when we are looking at villitis, these are the features that ring a bell that should be a red flag for you to look for potential infectious etiologies. So the first one is when the villitis is fairly diffuse. The second one is when the inflammatory infiltrate has plasma cells. So, as I said, chronic villitis of unknown etiology is typically in term placenta. So, if you have a preterm placenta with chronic villitis, you may suspect that it is of an infectious etiology. Acute villitis and intervillositis is actually infectious until proven otherwise. And if you see granulomas or giant cells, that also warrants an investigation for infectious etiology. So, which stains would you order? What we recommend is that for your usual chronic villitis that is lymphohistiocytic or lymphoplasmacytic, that you order immunostains for CMV, HSV1 and HSV2, and toxoplasma. If you see granulomas or giant cells, you should do an AFB special stain for acid fats bacilli. If it's an acute villitis, you should do stains for a Steiner stain that is a silver-based stain for Listeria. You should do stains for Spirochetes look at. Nowadays, there is a good immunohistochemical stain that you can use, or you can use the more old-fashioned special stain, and also gram stain, because group B streptococcus can cause acute villitis, and in those cases you tend to see lots of bacteria even within the fetal vasculature, so that's something you need to evaluate for. And syphilis, you can cause chronic villitis, but can also cause acute and chronic villitis. I'll now be showing some examples of villitis under the microscope. This is a case of quite subtle chronic villitis of unknown etiology. Most of the placental parenchyma looks normal. However, in some areas, we see that some villi are darker. We see that cluster, that cluster, that cluster, and darker usually means increased inflammatory cells. So that's what we're seeing. Those villi are infiltrated by lymphohistiocytic cells. It's hard to tell exactly which cell is which, but definitely they look different than the villi around them. So this is a case that is quite subtle, actually, that is quite easy to miss, of chronic villitis of unknown etiology. This is another case that is a little more obvious. So we spot on low power that area in which the villi look abnormal. And your first impulse may think this is increased perivenous fibrin or that's an infarct, but this is actually chronic villitis, and those other findings are a result of villitis. So what we see again when we compare the normal villi around this foci, those have increased inflammatory cells and look more blue. Usually you have a certain level of decreased vascularity. Eventually the villi do die off, as we can see here, as a result of villitis. So the trophoblast is necrotic, we don't see it anymore, and we have increasing perivenous fibrin. Sometimes we have apoptotic debris, so that's all expected for villitis. So this again is chronic villitis of unknown etiology of a higher grade. This is a high grade example in a term placenta. This next example, we start with some red flags that make you think that, well, maybe this is not just chronic villitis of unknown etiology. So when we look at this case here, we go from the chorionic plate on top to the maternal surface here at the bottom. Initially, again, you may think this is increased perivenous fibrin deposition, villous infarction, because yes, the tissue does look that. But when we look next door, we do find increased inflammation in this villi, actually quite substantial inflammation in this villi. And not only that, in this area that I dotted, there should be some plasma cells. I don't know how well they will project, but they are definitely there. Let me try to find them. We have one right here, for example. So, and I believe that's probably another one right there. So this is a lymphoplasmacytic diffuse villitis. So this is the type of a case that you want to do those immunostains we were talking about. I have yet another case of fairly severe villitis. So when you see something like this that affects most of the parenchyma, it's very diffuse with lots of necrosis, that's something that you shouldn't call chronic villitis of unknown etiology. I do the stains in those cases, and if the stains are negative, I call this high-grade chronic villitis, diffuse high-grade chronic villitis, and I write a note saying that microorganisms were not detected, so you should look for viral inclusions. They were not found, and let's say that all the stains you did were negative. I would still not call something like this villitis of unknown etiology. And then, of course, we have acute villitis, which this is an example of. On low power, it looks very similar to those diffuse chronic villitis that I showed, but the inflammatory infiltrate is different. So when we look on a higher power here, we see lots of neutrophils
inside the villus and the intervillus space as well. So this is acute villitis and intervillositis. It's infectious until proven otherwise. And this was likely a macro abscess grossly. I don't remember if this case actually we saw an abscess grossly, but both macro and micro abscesses are characteristic of Listeria and do require that you stains for that microorganism.